Hello, let's get started. We're talking about sodium and potassium up close today. Going to narrow down on these two. So things that we really need to pay attention to with sodium and potassium is what we're going to look at. So hello, my name is Rhoda Summer, and I'm a owner tutor of one-on-one NCLEX tutoring, and I've also written a book, NCLEX RN for Dummies. I have two other tutors, soon will be 3 or 4, who work with me. We love helping nursing students either in school or out of school. So here's what we're talking about today. We're talking about sodium and potassium, their function in the body, and what happens if they're low or high, and how does that affect my client, and when do I call the doctor? So we're going to talk about sodium first. Sodium regulates the fluid volume. It helps maintains blood volume, and sodium is reabsorbed in the kidney with water and potassium. That helps regulate this fluid and blood volume. Sodium interacts with calcium to maintain muscle contraction. So understand, when sodium goes low or high, that's going to affect the muscle contraction. It also stimulates conduction of the nerve impulses. So things that we need to know. Did you know sodium is a major cation of extracellular fluid? That's the fluid outside the cell. And sodium, I already said, is reabsorbed by the kidney. It affects blood pressure. So sodium intake should be limited to 2,300 milligrams of sodium per day. That's the whole, for anybody. That's not just people that are sick. That's anybody. And really, here in America, I will say that our diets contain more and more salt, depending on where we eat and what we eat. Did you know sodium can be low or high? Okay, and each of them have their own name. So hyponatremia is low sodium, and hypernatremia is high sodium. So hyponatremia, the range for sodium is 135 to 145. So anything below 135 would require me to call the doctor, and it's hyponatremia. Now, the cardiovascular varies depending on the levels of the fluid in the vascular system, and we're going to talk about those effects in a little bit here. The respiratory, these changes are late manifestations. The difficulty breathing, the shallow, ineffective, these are late when the sodium has really dropped. Hypernatremia is anything above 145. Again, need to call the doctor. Again, the heart rate and the BP vary depending on the volume, but let's talk about why that is. The reason that is because sodium affects calcium, and calcium is the main electrolyte that affects the contraction of the heart. So if sodium is low, it will decrease, or high, it will decrease the contractibility of the heart, of that ventricle muscle contracting. So fluid level and how rapidly it happens will affect the blood pressure and the heart rate. So hyponatremia, the neuromuscular, they have general muscle weakness that is worse in the extremities. So I need to check the patient for strength and reflexes, remembering that the muscle part is because of the action between calcium and sodium. The CNS, the first obvious sign of hyponatremia is a change in their level of consciousness. They have a headache, they have personality disorder changes, they have confusion, seizures, and a coma. Hypernatremia. So neuromuscular, they have spontaneous muscle twitching and irregular muscle contractions. That's early sign of skeletal muscle weakness. But then the deep tendon reflexes are diminished or absent the further in we go. The CNS, they have that altered level of consciousness. And again, this is the first sign that something is wrong. They can have problems with memory and, of course, the confusion, agitation, and seizures. So hyponatremia with the gastrointestinal, it increases the abdominal cramping, the diarrhea, the nausea. With renal, it's increased urine output, and the integument, they have dry mucous membranes. Hypernatremia, they have extreme thirst in the gastrointestinal tract. Their renal is decreased output. The integument has the presence or the absence of edema, depending on those fluid changes. If they're in fluid overload, if they have hypervolemic, they can have the edema. They can have dry, sticky tongue and mucous membranes, or they can have dry, flushed skin. So, all right, we're going to talk here in depth about these three fluid levels. We have normovolemic, which is rapid pulse, normal blood pressure. Then we have hypovolemic, which is thready, weak, rapid pulse rate, hypotension, flat neck veins, normal or low central venous pressure, and then hypervolemic, where we have a rapid bounding pulse, blood pressure is normal or elevated, and have an elevated central venous pressure. So if I have low fluid, which is the hypovolemic, I have decreased plasma volume, which increases my heart rate. A lot of students don't get this. If there is something going wrong with the perfusion of the body, the heart is one of the first ones that responds to that because it thinks that it's not doing its job. So it speeds up. Okay. But with hypovolemic, because there's not enough fluid, it's weak, it's thready. That means I can obliterate it when I try to palpate the pulse. The peripheral pulses are hard to palpate, and the BP is down, and they have severe hypotension. And that can happen mainly when they change positions. Then the high fluid or hypervolemic is rapid bounding pulse. It's when I'm in fluid overload. The pulse is bounding. There's so much fluid when the heart contracts and pushes the blood out and makes that pulse, it bounds against the sides of the vein or artery. The pulse is normal or high BP. There's peripheral pulses that are full, but can be hard to palpate if I'm truly in fluid overload. If I have hypervolemic, I will also could have edema. And so it might be hard to get those peripheral pulses because of that. So those are some very important facts that we need to know about hyper and hyponatremia. So this is a quote I found, that the human diet for millions of years did not contain any added salt. Only sodium present was in natural foods. adding up to about 1,000 milligrams of sodium per day. And you can think about the effect that our diet that we now have here in the United States and around the world has changed by the amount of sodium that we've added to our diet in canned products, in the frozen TV dinners we get, and the processed foods to make our lives easier has added more sodium into our life. So some interventions for hyponatremia. We need to monitor the electrolytes, especially sodium. We need to provide a diet high in sodium. And if the fluid volume deficit accompanies, then I'm going to be giving IV of normal saline to restore the sodium content and the fluid volume. Now I want to stop here for a minute and talk about causes. It could be an excessive or long use of diuretics. It could be wound drainage. It could be decreased secretion of aldosterone. It could be kidney disease. It could be a low salt diet. It could be hyperglycemia. It could be excessive ingestion of hypotonic fluids. Remember, when we give hypotonic, that can make the patient go hyponatremic. Freshwater submersion accident where they drowned in fresh water, irrigation with hypotonic fluids, SIADH, and heart failure. The priority with hyponatremia is to monitor the patient's response to therapy and to prevent the hypernatremia and fluid overload. Some more interventions. If accompanied by fluid volume excess, may give osmotic diuretics to encourage excretion of water rather than sodium. And if hyponatremia is due to an inappropriate amount of antidiuretic hormone, then use the antagonist for antidiuretic hormone. And last, if they're taking lithium, you need to monitor the lithium level. Hyponatremia can cause lithium toxicity. Now some interventions for hypernatremia. Again, I need to monitor the electrolytes, especially sodium. I need to provide a diet low in sodium foods. And if the fluid volume deficit accompanies, I'm going to give an IV. So some causes, again, I'm going to stop here. Causes are hyperaldosteronism, kidney failure, corticosteroids, Cushing's. Go get my lab sheet if you don't understand the Cushing aldosterone labs. There are 5 that are affected, and students all the time are getting which one has potassium high, which one has sodium. You need to go get them. If you don't know them, go get my cheat sheet, just a short, brief thing. Then it also is caused by excessive oral sodium ingestion, excessive IV salt-containing fluid. If I've given too much of IVs with salt, or hypertonic sodium IVs, if they're MPO, if they have an increased rate of metabolism, or they're hyperventilating, they have an infection, they have watery diarrhea or dehydration. The priority here with hypernatremia is to monitor their response to what we're doing, these interventions, and ensure they have a safe environment. Remember, they have those weak muscles, and we are going to prevent hyponatremia and dehydration to promote that safe environment. So some interventions for hypernatremia. If renal excretion is inadequate, then we need to give diuretics that encourage sodium excretion. An example would be permosified. And then lastly, we need to restrict sodium intake. Now we're going to talk about potassium. Oh my goodness, this is the heartbeat of the electrolytes in my mind. It regulates the conduction of the cardiac rhythm. It transmits the electrical impulses in multiple body systems, and it assists with acid-base imbalance. Potassium is within the membranes of all the body cells. The main potassium is the main one in there. And that sodium potassium pump is the main controller of potassium, and it moves extra sodium from the intracell inside the cell to outside the cell as potassium goes in. That's that pump. The kidneys also help control the potassium excretion with aldosterone. So potassium, did you know that it's the major cation of intercellular fluid? That's inside the cell. Potassium is excreted through the kidneys, and it plays a huge role in repolarization of the cardiac cells to get ready for the next contraction. When we're talking about repolarization and potassium, you have to understand this is a car without gas. When I don't have enough gas, my car won't move. When my body doesn't have enough potassium, the repolarization doesn't happen the way it should. So some humor in the middle of this. I hate it when people text me K. I rarely am in the mood to talk about potassium. Got to have some fun in here, as this is heavy stuff. So hypokalemia, what happens? So the range for this is anything below 3.5. The range for potassium is 3.5 to 5. So anything below 3.5 would be hypokalemic. And hypokalemic, before I get started even into any of the systems, you need to know it is life-threatening because of the effect on every single system, because potassium is the lifeblood, the heart of this electrolyte thing. So hypokalemia, they're going to be thready, weak, irregular pulse. They're going to have weak peripheral pulses. They're going to have orthostatic hypotension when they try to change position, and they're going to have dysrhythmias. The causes of hypokalemia are drugs like Lasix, aldosterone, Cushing's, vomiting, prolonged NG suction. Understand that essentially vomiting and NG suction prolonged is the same thing. I'm pulling off the same thing. Kidney disease, being MPO, associated conditions with hypokalemia would be alkalosis, hyperinsulinism, hyperalimentation or TPN, and water intoxication. When I'm dealing with the cardiac system and my patient potentially has hypokalemia, I need to be assessing the peripheral pulses. I need to be monitoring that ECG, because it'll be the T wave, and the T wave is the repolarization. It will be the T wave that is affected, and it's going to be inverted, depressed, flat, and it can create a U wave. So hypokalemia in the lungs. So they have slow, ineffective respirations that result from the weakness of the skeletal muscles. So those same muscles that help me move, that help me do what I do every day, also help me breathe. And if they are profoundly weak, it is going to affect my ability to breathe. And so I'm going to have diminished breath sounds. And this is my priority. It is life-threatening if they're hypokalemic and it's affecting their ability to breathe. Now, in the central nervous system, anxiety, lethargy, confusion, and coma are the big ones. In the skeletal muscles, you got the weakness, the leg cramps. You can get loss of tactile discrimination. They can have paresthesia and also deep tendon hyporeflexia. Altered mental status can lead to that acute confusion and go into the coma as this gets worse with hypokalemia. So hypokalemia in the digestive system. Understand that the smooth muscle contractions decrease and occur with hypokalemia, and this leads to decreased motility and peristalsis. And this can cause a paralytic ileus, where the gut has just stopped. So the symptoms of this would be the nausea, the vomiting, the constipation, abdominal distension. And I can have hypoactive to absent bowel sounds with this. And hyperkalemia, we're moving to the opposite. Too much potassium. Now this is anything above 5.0 that I would call to the doctor. This is the most common death for hypokalemic, and it has to do with the heart. They have slow, irregular heart rate. They have a decreased blood pressure and dysrhythmias. So bradycardia, when I say slow, it's Brady. So less than 60 beats per minute. They can have hypotension. They have ECG changes. The potassium is in that T wave, the repolarization. So I have too much gas now and it spikes like a QRS. But all of the rest of it is slowed down because it's happening too fast. So I have a prolonged PR interval, a flat or absent P wave, and my QRS is really wide. Higher potassium are more likely have those ectopic beats, the extra ones. This can cause, ladies and gentlemen, this can cause heart block, asystole, VFib, which are all life-threatening. Hyperkalemia is life-threatening to the heart. So hyperkalemia for the lungs. The lungs really are not affected by hyperkalemia until it is really late. It is profound weakness of the skeletal muscles leading to that respiratory failure. Then the neuromuscular. There are two phases to the neuromuscular with hyperkalemia. Early on, the skeletal muscles twitch. They're twitching. We get tingling and burning, followed by numbness in the hands and feet. And the patient is very aware of this. But then as it gets later, as it worsens, the twitching, the muscles get weak from that. And that leads to the paralysis. And it moves from the hands and feet up. The respiratory muscles are the last ones that are affected. And that's when the potassium level is at a lethal amount. Again, hyperkalemia, if you're not hearing me, is life-threatening. So hyperkalemia in the digestive system. It actually increases motility, have hyperactive bowel sounds and diarrhea. They can have spastic colon activity and hyperactive bowel sounds. So now let's talk some interventions. So interventions for hypokalemia. Need to monitor the electrolyte labs. Need to provide a diet high in potassium and provide potassium supplements as ordered and remove potassium depleting drugs. Remind the doc, hey, by the way, this patient's on Lasix and they now have hypokalemia. Do you want to change that? The priorities here is to ensure adequate oxygenation and that the patient safety for fall prevention and prevention of injury, because I'm going to be giving potassium, and monitor their response to therapy. More interventions. I need to give potassium IV. Be sure to do it, not to do it IV push, give it slowly, and monitor that vein for irritation and infiltration. I also need to, when I'm giving potassium, need to monitor the output, because potassium is given or is gotten rid of by the kidney. And if the kidney's not functioning, I can throw this patient into hyperkalemia. I need to implement those safety precautions for falls. And again, monitor for respiratory difficulties due to the weak muscles. So interventions for hyperkalemia. The priority here is to prevent those cardiac complications. Continue to work with the safety due to falls and prevention, monitoring the patient's response to therapy, and I need to do health teaching. So monitor their electrolytes, provide a diet low in potassium foods, eliminate potassium supplements, give potassium excreting diuretics such as ordered, do the cardiac monitoring for early recognition of the dysrhythmias, and health teaching to prevent the hyperkalemia. Includes the drugs, the diet, and the manifestations. Electrolytes are vitally important to nursing care. It helps the nurse to know how to intervene. If we know the signs and symptoms, ladies and gentlemen, we can catch these things early and they don't go into the life-threatening situations. So let's review. The range for sodium is 135 to 145. Sodium manages fluid balance. Sodium and calcium help with muscle contraction and nerves. Potassium's range is 3.5 to 5. It plays a huge role in the cardiac contractions, especially the repolarization, the getting ready for the next beat. And if that's not working right, then the patient is at severe risk for life-threatening complication. And that it is excreted and regulated through the kidneys. I want to thank you for joining me today. And if you have any questions, you can reach me at rhotasummer1on1@clextutoring.com. I hope to see you next time. Bye-bye.